Hello everyone, welcome back to LIFEHUE YouTube channel. This is the fourth video of our complete general medicine series. In this series, we are going to cover practical and theoretical topics of general medicine. In our last video, we talked about stomatitis and oral ulcer, gingival hyperplasia, dysphagia, gastritis, and peptic ulcer, which were the topics of gastrointestinal system. In this video, we will talk about hepatobiliary system. Topics are jaundice, acute viral hepatitis, cirrhosis of liver, ascites, and hepatomegaly. Our first topic is jaundice. It is yellow discoloration of skin and mucous membrane due to deposition of bilirubin in the tissues. The deposition of bilirubin in the tissues occur when the serum bilirubin level is raised. This condition is known as hyperbilirubinemia. The normal total serum bilirubin level is 0.3 to 1 milligram per deciliter. Sclera has a high affinity for bilirubin due to their rich elastin content. The other sites to be looked for the evidence of jaundice are mucosa of oral cavity, underneath the tongue and skin. Urine is dark colored in color due to excretion of conjugated bilirubin. In this photo you can see we look for the evidence of jaundice in lower part of sclera. Jaundice is classified into two types, unconjugated and conjugated. The conjugated type is due to Dubin-Johnson syndrome and Rotter syndrome, hepatocellular diseases, or cholestatic jaundice, which is also known as obstructive jaundice, while the unconjugated type is due to overproduction of bilirubin or impaired hepatic metabolism. Now, acute viral hepatitis. Acute viral hepatitis is a systemic viral infection characterized by predominant involvement of liver. It is caused by one of the specific hepatitis virus like hepatitis A virus, hepatitis B virus, hepatitis C virus, hepatitis D virus, and hepatitis E virus. Other viruses are cytomegalovirus, Epstein-Barr virus, herpes simplex virus, and yellow fever virus. Hepatitis B is most important among them, and its symptoms are jaundice, fever, yellow dark urine, pale poop, nausea, vomiting, pain in the right side of the abdomen, joint pain, hives, headache, weakness, fatigue, and loss of appetite. Clinical features of acute hepatitis are divided under the various stages. Firstly, prodromal stage, in which non-specific systemic symptoms like anorexia, nausea, vomiting, headache, fatigue, malaise, myalgia, and arthralgia may occur. Second is icteric phase. Patient may notice dark urine and yellowish discoloration of eyes and skin. Clay-colored stool and pruritus suggest cholestasis. In recovery phase, there are improvement in general symptoms and diminution of jaundice. Signs of jaundice seen in sclera, which becomes yellow in color, and the skin may show stretch marks due to pruritus. Complication of jaundice may be hepatic or extrahepatic. Hepatic complications are acute fulminant hepatitis, relapsing hepatitis, cholestatic hepatitis, chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Extrahepatic complications are aplastic anemia, Henoch-Schönlein purpura, glomerulonephritis, papular acrodermatitis, myelitis, neuropathy, arthritis, cryoglobulinemia. Treatment for hepatitis is to avoid much of physical activity, but bed rest is not recommended until it is a severe case. Drugs, especially hepatotoxic and those which are metabolized in liver, are restricted. Alcohol intake should be avoided. There is no specific therapy, and liver transplantation may be required in cases of acute fulminant hepatic failure. Cirrhosis of liver. It is the end result of the hepatocellular injury characterized by the presence of extensive fibrosis, regenerative nodules, and loss of liver architecture. Two of the most common causes of cirrhosis are viral hepatitis, especially B, D, and C, and prolonged excessive use of alcohol. Other than that, non-alcoholic steatohepatitis, also known as NASH, is also a cause. Other causes are autoimmune hepatitis, drug-induced biliary cirrhosis, hemochromatosis, Wilson's disease, cardiac cirrhosis, alpha-1 antitrypsin deficiency, and cryptogenic cirrhosis. Clinical features of cirrhosis may show features due to hepatocellular dysfunctions, which are jaundice, ascites, hepatomegaly, spider nevi and palmar erythema, gynecomastia, testicular atrophy, menstrual abnormalities, breast atrophy, bleeding tendency, hepatic encephalopathy. Features due to portal hypertension are ascites, splenomegaly, variceal bleeding, hepatic encephalopathy. Other clinical features are parotid and lacrimal gland enlargement, clubbing, opaque nails, Dupuytren contracture, and skin pigmentation. Lab features for finding of cirrhosis of liver are blood examinations, imaging, which is ultrasonography, is helpful in evaluation of liver size, texture, ascites, portal hypertension, and splenomegaly, endoscopy, and liver biopsy. Biopsy helps in assessment of the severity of cirrhotic changes. Management of cirrhosis includes general management, treatment of specific cause, management of complication, and liver transplantation. General management includes diet, which should have adequate amount of protein and calories, vitamin supplement, and salt restriction. Medications which are hepatotoxic or metabolized in liver should not be given or should be given with caution. Treatment of specific cause like alcohol, stoppage is mandatory in alcoholic cirrhosis, and specific therapy is needed in hemochromatosis and Wilson's disease. Next topic is ascites. Ascites is the accumulation of excess fluid in the peritoneal cavity. Normal fluid volume in peritoneal cavity is less than 20 ml. Causes for ascites in normal peritoneum may be cirrhosis with portal hypertension, congestive heart failure, hypoproteinemia, Budd-Chiari syndrome, pancreatitis, biliary ascites, chylous ascites, and Meg syndrome. Diseased peritoneum, tuberculous peritonitis, bacterial peritonitis, and malignancy. Investigations include ultrasonography and paracentesis. Ultrasonography of abdomen can detect presence of minimal amount of fluid and is helpful when clinical signs are not present. Abdominal paracentesis is performed as a routine investigation to determine the cause. It can be performed under ultrasound guidance. 50 to 100 ml of fluid is drained and examined for the color, total differential, cell count, and malignant cells. Management of ascites is restriction of salt in the diet, diuretics are given, therapeutic paracentesis is needed in massive ascites. Next topic is hepatomegaly. The liver is normally not palpable, however, it is palpable in right upper abdomen when enlarged. The size of the liver is usually expressed in centimeter below the right costal margin. The consistency of liver should be noted as soft, firm, or hard. The surface may be smooth or nodular, and the edges may be sharp, regular, or irregular. Liver may be non-tender or tender to touch. Causes for hepatomegaly are vascular causes like congestive heart failure, hepatic vein thrombosis, inflammatory causes like hepatitis, cirrhosis, liver abscess, neoplasm like hepatoma, metastasis, lymphoma, leukemia, granulomatous causes like tuberculosis, sarcoidosis, and infiltrative causes like fatty liver, non-alcoholic steatohepatitis, amyloidosis, hemochromatosis, storage disorders, and biliary tract obstruction. This comes to the end of today's lecture. We will cover diarrhea, dysentery, amoebiasis, and malabsorption in our next video. Thank you for following till here. If you liked the video, don't forget to hit the like button. Subscribe to the channel for further updates.